Friends, I'm really honored and I'm thankful to Dr. Chauhan and his team to give me yet another chance to moderate the session. 809 is a very auspicious number. I am supposed to introduce Dr. Nangia, Vivek Nangia. सर आपके तो नाम में विवेक है, तो आप विवेक बांटोगे हमें पता है, और कौन नहीं जानता आपको। मुझे ये कह तो दिया कि मैं आपको इंट्रोड्यूस करूं, पर मैं किसको इंट्रोड्यूस कर रहा हूं? जो सब जानते हैं आपको, उनसे मैं कह रहा हूं कि ये विवेक नांगिया जी हैं। सूरज को दीपक दिखा रहा हूं, फिर भी मैं बता रहा हूं कि ही इज ए प्रिंसिपल डायरेक्टर एंड हेड ऑफ इंस्टीट्यूट ऑफ रेस्पिरेटरी एंड क्रिटिकल केयर ऑफ स्लीप मेडिसिन, Max Hospital, Sake. He is Chief of Pulmonary Services at Max Healthcare of India. So it is Pan Max. So I will skip so many of your achievements. You are an alumni of AMU, where many of my friends are related to. And interest of your special interest is, I know. It is infectious diseases, hospital infectious, clinical infection and pulmonary infectious diseases. You have attained so many awards, trained abroad, widely traveled. So I will save time while introducing you, because I know I will save time for interaction, which will be more meaningful. And I think you will be the first speaker, and the next speaker, the budding pulmonologist, Dr. Amina Mobashir, very knowledgeable, and she has membership and association with many prestigious hospitals. And I will stop short here while introducing. I would say rather we will know from them and learn more. Dr. Nangia sir, please.
Very good evening, everybody. It's indeed a pleasure and honor to be here before all of you, such an august gathering this evening. Especially so because I'm joined by my very dear colleague, Dr. Amina Mobashir, who is a consultant with us in the department. They're also joined here today with Dr. Manjunath, who was our PNB student at Fortis Basant Kunj, and now is a leading pulmonologist in Bangalore, and has come here, was here on a workshop, so we invited him here today to join us over there. It's also a pleasure to have Dr. Heman, my former colleague from Mathura Hospital, Dr. Manish, former colleague from Mathura Hospital, to be here. So it's like, it's literally homecoming for me. But before we start with our lecture, we also have Dr. Mangla here, and also such a wide, diverse group. We have oncologists, we have microbiologists all here with us. It's really a pleasure. And endocrinologists also. So before we start the formal lecture, let me invite Dr. Kagandi. She'll introduce the concept of a severe asthma clinic to you all, and then we'll take it from there.
Very good evening, everyone. Apologies for, I know we all are dying to hear from our esteemed speakers today. Just kind of fetching 2-3 minutes before that. Just wanted to set the context on, what's the importance of severe asthma clinic. And to begin with, we are really fortunate enough to get this opportunity to collaborate with Dr. Vivek to establish, the severe asthma clinic in this city. And actually, just wanted to take you all through why there is a need of severe asthma clinics in this country, in this city. We know that severe asthma per se it is very less, 5 to 10% of our total asthma population are actually through severe asthma patients. But identifying them is really a challenge, and there are many constraints around managing such patients. It's because it's not a direct diagnosis, it's a diagnosis of a mission. You have to make sure patient is using the inhalers correctly, he is on optimized dose of the inhalers, all the comorbidities are taken care of, and then you make sure if the patient still is uncontrolled, then probably he is a severe asthma patient, and then these patients need further hand-holding with respect to counseling, right? Why they're different from mild to moderate asthma, why they need additional treatments which are more costlier to control their symptoms. So it actually needs a very systematic approach, and that's why a dedicated clinic is very, very important. These are the patients who land up in emergencies, hospitals, consuming almost 50 to 60% of the total asthma resources. And so that's why we need a severe asthma clinic, so that we have a systematic everything, under one roof these patients are taken care of and, handhold by the treating doctor. We have this objective. We from AstraZeneca, since we work in this space, we are trying to, not just support the treatment here, but also work across the patient journey, how we can collaborate with the people, with the specialists who have keen interest in asthma, how we can upgrade them, especially the severe asthma practice, how we can collaborate with them, provide them the resources which are possible. And for that, we have created a lot of resources. We have, some of the resources are already there on your tables, and here as well. You may have look during the dinner time. A systematic 7-step identification performers are there, proper assessment performers where the details of the patients can be captured, and later on that can be utilized for publications. And even our medical team provide trainings to the resources or the counselors at these centers if required. And then there are various patient education booklets or patient awareness programs for which we can collaborate. And then apart from that, we also want these centers to be more visible across the country. So anything, any ideas you have how we can together, improve the lives of severe asthma patients, we are open to collaborate. And with that, I will not just, all these materials are there on your tables, and I just don't want, to take any more time and start. Let's together, welcome Dr. Nangia and hear from him how to manage a severe asthma patient as well as an overall holistic, how an asthma patient should be managed. So with that, I just end, and I am really thankful to Dr. Vivek and the Max Hospital for, giving us this opportunity to work together.
Good evening, everybody, again. I'd like to thank Physicians Forum of India and Dr. Chauhan for giving us this opportunity to be here. We would like to announce the opening of a severe asthma clinic that we run every Tuesday of the week between 12 and 3 p.m. This is dedicated to all those patients who suffer with allergy, asthma, and Dr. Amina Mobashir is leading the show for us there. She's been trained from Harvard in allergies and asthmas. So, my talk is going to be in 2 parts. First part is to talk about what are the newer guidelines on the management of asthma patient, and these are the guidelines based on GINA. GINA is a global initiative for asthma, and they come out with guidelines every year. The complete body dedicated to forming guidelines based on the most recent articles and the most recent research that has happened. And the second part would be to talk about the drug benralizumab, which has actually changed the complete landscape of management of severe asthma patients. So bronchial asthma, as we all know, is a common chronic respiratory disease affecting 1 to 18% of the population in different countries. A heterogeneous disease usually characterized by chronic airway inflammation. So you need to remember the word inflammation here, which I think I should have underlined. Second thing is, it has variable symptoms. The symptoms may be there in the morning, may not be there in the evening. Patients say that they are breathless in late night hours or early morning hours, but when they come to you in the OPD in the afternoon or evening, by then you don't find any way. So you keep wondering, is this asthma, is it not asthma? So actually where there is a variation means that there is a very high likelihood that this patient may be having asthma. Then they may be having seasonal variations, more during the change of seasons, more during autumn, more during April. So fall, that is the time they may have more symptoms. Wheezing, shortness of breath, cough, usually associated with cold, running nose, blocked nose, post-nasal drip is extremely common symptomatology that you would face in your practice. So both the symptoms as well as the airflow limitation would characteristically vary over a period of time. They would also vary according to their intensity. The common triggers we all know are the exercise. There is something called an exercise-induced asthma. There are allergens, irritant exposure, change in weather, virals, respiratory infections, air pollution outside, indoor air pollution. All of them can trigger bronchial asthma. The symptoms, they may resolve on their own also sometimes or may require treatment, but then it is episodic. It comes and it goes. But what happens is that with every exacerbation that the patient has, there is some irreversible damage that is left behind in the lungs. That is what is our concern. So episodic flares may keep happening and resulting in a significant burden. So this is a basic profile that we test in all our patients. CBC, an absolute eosinophil count, serum IgE levels, their chest X-ray. We usually evaluate most of our patients for sinusitis because that's present in almost 70 to 80% of the patient that you see. If the person is elderly, then it's important to rule out an underlying cardiac illness because you never know, the symptoms may be overlapping. Nocturnal symptoms could be in cardiac patients as well and asthma patients as well because of the diurnal variation. And then of course a pulmonary function test and FeNO. FeNO is the forced exhaled nitric oxide test to look at the inflammation in the airways. This is something that we're doing routinely now for all our patients. So diagnosis is basically based on symptomatology, triggers, history, and then a pulmonary function test. A pulmonary function test, when you see, you look at the variability or reversibility in these patients. There's a parameter called FEV1, that is the forced expiratory volume within the first second, and the variation before bronchodilator and after bronchodilator if it is more than 12% or more than 200 ml, or even better if it is more than 15% or more than 400 ml, that is confirmatory of an underlying bronchial asthma. You could even ask the patient to keep a peak flow meter with them and keep testing their flows, peak flows at home itself, morning, evening, afternoon, different times, different days, and then see the variation. A variation in the peak flow rate of more than 10%. If somebody had 360 one day and 400 the other day, that means it's more than 10%. So that again is significant, and that again is indicative that the patient may be having an underlying bronchial asthma. I'll come to why is it important. It's important to know whether the patient has bronchial asthma or chronic obstructive pulmonary disease or anything else, because the lines of treatment are totally different now, especially between asthma and COPD. They're not the same. So based on all these clinical profiles, there are 5 clinical phenotypes that you can see in your clinical practice. First is allergic asthma, where patients give you a history of allergy. IgE is positive, eosinophils may be elevated. This is called a Th2 inflammation. In this group of patients, they are very good well responders to inhaled corticosteroids. And eosinophils may be present in the sputum as well. In the non-allergic variety, the sputum is usually neutrophilic, maybe eosinophilic, or may even be paucicellular. And their response to inhaled corticosteroids is not as good. Then you have the adult onset, which is also sometimes intermixed with occupational asthma, where people develop features when they go into a particular place of work and they, Monday to Friday they have symptoms, Saturday, Sunday when it is an off, the symptoms also subside. So again, you have to take that history properly and see. Adult onset, late onset is usually particularly common in women. This is when in their middle ages the people come with first time asthma-like features, they've never had asthma in the past. Then again they tend to require a very high dose of inhaled corticosteroids. And finally there is a variety which is called persistent airflow limitation, where because of chronic inflammation in the airways, there is some remodeling that has happened which does not allow the reversibility to be present. Yet we don't label them as COPD, we label them as bronchial asthma. Why? Because they've had a history, their features have been like bronchial asthma, now they are progressing towards COPD or a fixed airway obstruction as we call it. And then again, there is asthma with obesity. Obese people are also prone to developing asthma in addition to so many other complications that can possibly be there. But as I said, every wheezing in the chest is not asthma. Patient is coming to you with breathlessness, you put a stethoscope on the chest, you hear a wheezing sound, that doesn't mean it's asthma only. It could be anything else. Also, it could just be a chronic upper airway cough syndrome. Patient is having recurrent cough, sore throat, post-nasal drip. This inducible laryngeal obstruction is a new terminology that has been introduced this year. This usually refers to a constellation of dyspnea and inspiratory stridor. So again, you have to take a proper history. There could be hyperventilation, dysfunctional breathing, bronchiectasis, chronic obstructive pulmonary disease. So while in asthma I've been saying about inhaled corticosteroids, we tend to avoid inhaled corticosteroids in patients with COPD now. Therefore, it's very important. It's important to rule out cardiac failure, a medication-related cough, which is very commonly seen with ACE inhibitors. Patients who are hypertensive, we must take history of what medication they are taking. A beta blocker may be worsening their wheeze, an ACE inhibitor may be causing a cough. So you need to take that history properly. Then a sudden onset of dyspnea, patient has come with breathlessness. Some people label it as silent chest because they're not getting any wheeze and yet the patient is very breathless, oxygen levels are low. Actually, I would think of pulmonary embolism. You know, there was a time when we were in medical college and you would think pulmonary embolism is rare and doesn't happen in India, to now when we see almost 2 or 3 patients of pulmonary embolism every month. So it is practically that common. So that also is something that we must keep in mind when evaluating a patient with breathlessness. And of course, TB is like an ever common disease in our country. So the long-term goals of asthma management are to achieve a good control of symptoms and maintain normal activity levels and to minimize exacerbations, asthma-related deaths and persistent airflow limitation and side effects. So the idea is both. One is to get the patient symptomatic relief and also get a good quality of life in future and in times to come. So the categories of asthma medication are 3 basically. One is a controller medication, then you have the reliever medication, and then you have the add-on therapies. So controller medication are basically those medicines which are given as a maintenance therapy, which again, you know, like diabetes, hypertension, heart disease. Asthma is also a chronic disease which requires long-term management. It is not a short-term. Except, of course, if it is a viral-induced wheezing as a change of season like it is these days, then you may not want to treat it for very long. But once wheezing sets in the chest, it results in an inflammatory cascade in the airways, which takes time to go. It doesn't go so easily. So you need to give them time and you need to give them the inhaled therapies for a prolonged period to get them out of it completely. Otherwise, they keep relapsing and may go into a persistent fixed airway obstruction at times. So there is a controller medication that needs to be given throughout for a prolonged period. In between, if the patient has symptoms, you could give them a reliever therapy. I'll just come to the 2 classes. And then you have the add-on therapies which are given to patients if the symptoms still persist despite giving them a controller and a reliever, and if the symptoms are persisting, then we give them the add-on therapies. This is the kind of chart that has been recommended by Gina to be followed, and it's a very simple chart. Let me break it up for you. This is the first step. This is the first track that we need to follow, which is strongly recommended to be followed. Again, it's symptom based. So if somebody has symptoms which are less than twice a month and no risk factor for exacerbation, then you just put the patient on a as needed low dose inhaled corticosteroid and formoterol combination. You just put them on an SOS kind of a basis, and this would act as a controller. And if in between the patient develops breathlessness again, then you may give a low dose ICS formoterol extra dosage. If the symptoms increase to more than 2 times in a week, so 2 times in a month, then you need to give them a continuous low dose maintenance inhaled corticosteroid with a formoterol combination, with an ICS formoterol combination as an SOS therapy. So ICS inhaled corticosteroid with formoterol forms the backbone of treatment of asthma patients. This, you go on increasing the dosage to medium dose ICS with formoterol. If patient still has continuous symptoms, then we go on to add a long-acting muscarinic agent like a tiotropium or a glycopyrronium, and also consider high-dose maintenance, and then there are these other therapies that will come to subsequently. Let me present this case to you of a 22-year-old male with cough, cold, shortness of breath for 7 days. Seasonal variation is there in this patient. On examination, there is a wheeze present. Chest X-ray was within normal limits. PFT was showing an FEV1 with post-bronchodilator response of more than 20%. So what is the diagnosis here? Bronchial asthma. Right. And what is wrong with the prescription here? This is a prescription which has come from one of the leading hospitals of our country. And I just saw the patient today only, so it was just a chance. ICS is missing from this prescription. This is just a short-acting beta agonist and a combination of short-acting muscarinic agent. So SABA and SAMA combination, but there is no long-acting bronchodilator nor an ICS in this prescription. So early initiation of inhaled corticosteroids changes the complete scene for a patient of bronchial asthma. It should be started as soon as the diagnosis of asthma is made. It leads to greater improvement in lung functions than if the symptoms have been present for more than 2 to 4 years. And after this time, a higher ICS seems to be required in these patients to control, and they may even go into a permanent fixed airway obstruction. Patients who have not been taking ICS experience severe exacerbations and have a greater long-term decline in their lung functions. Short-acting beta agonist, as was present in the prescription, is no longer being recommended. I mean, not the first-line recommendation. Of course, it could be used as a backup in these patients, because we have a formoterol which is available now. Formoterol is very rapid acting, as fast as a short-acting beta agonist is, but the effect is longer. So it serves both purposes: rapid onset of action and a prolonged action of the medication. So it is as effective as short-acting beta agonist is. It reduces the risk of severe exacerbation by 15 to 45%, and the use of regular and frequent LABA without ICS is strongly discouraged. So again, ICS has to be there in your prescription. It can't be without an ICS. SABA only treatment is strongly objected to, strongly rejected by people now. It is no longer recommended by GINA. Patients whose asthma is treated with SABA alone tend to have a much higher risk of exacerbation, much higher risk of death because of an exacerbation. Overuse of SABA, that means if somebody is using more than 3 canisters in a year, that means the asthma is very poorly controlled and we need to look into it properly. This could result in increased risk of asthma exacerbations. There are various oral formulations available now where they're combining a theophylline with a beta agonist tablet. Again, that is not recommended. They have serious side effects and should not be used. You would have used so much of acebrophylline and with so many combinations, they actually can be harmful. Then inhaled anticholinergics could also be used like tiotropium or glycopyrronium, but never without an inhaled corticosteroid in patients with asthma. As monotherapy also now in COPD patients, it is no longer being recommended. Even in COPD, it is preferred to use a combination of a long-acting beta agonist like formoterol, indacaterol, in combination with long-acting muscarinic agent like tiotropium or glycopyrronium. In case patient is not wanting to follow that LABA and ICS route, then you could give them a short-acting beta agonist, but as I said, it has its own drawbacks. But what you need to remember is that every time you give a short-acting beta agonist, it must be with an inhaled corticosteroid. So it has to be a combination of the two, it cannot be. Inhaled corticosteroid has to be there when you are treating a patient with asthma. And inhaled corticosteroids are the budesonides and fluticazones, but budesonide is the preferred molecule again because in COPD patients there was a study which showed it was associated with lesser incidence of pneumonias that could occur because of ICS. Inhaled corticosteroids would usually have side effects like oral thrush, like gingivitis and vocal cord dysfunctions, dysphonias, and also pneumonias. So you need to be careful about that. So this group also you keep on stepping up the dosage if you're using a SABA with ICS, but ICS has to be there in the management of these patients. And then, despite that, if the patient is not coming under control, we have the options of using a leukotriene receptor antagonist like a montelukast and SLIT. SLIT is a sublingual immunotherapy for these patients against HDM. HDM is house dust mite. So house dust mite related desensitization can be conducted in these patients. But what is important also is that every time that the patient comes back to you, you must confirm the diagnosis, evaluate the patient, check the inhaler technique, adherence to therapy, all that needs to be checked. The comorbidities need to be looked into. If there is a comorbidity, we must treat that aggressively. Then there are newer add-on therapies that are now available and recommended like azithromycin, which can be given up till 3 to 6 months as 500 mg on alternate day, but if when you are doing it, you need to be careful that there is no atypical mycobacterial infection that the patient is suffering from. So get a sputum examination and a chest X-ray done before that. Also that it could result into a QTC prolongation, so you need to keep checking the ECGs quite often. And also there is a fear that it may result in drug-resistant infections. That is theoretically possible, but then it is still recommended in this group of patients up till 6 months. Vitamin D is one thing which is now being recommended probably in every situation, I feel, even in sepsis, asthma, COPD, so also in bronchial asthma, where low vitamin D has been linked to impaired lung function, higher exacerbations, and reduced response to steroids. So vitamin D supplementation may reduce the rate of asthma exacerbation with systemic corticosteroids and may improve symptom control also in these patients. Yet another modality that has been introduced in the management of asthma, especially the non-allergic asthma and allergic asthma when fails on therapy, is bronchial thermoplasty. We've done this in 2 of our patients with very good results. Bronchial thermoplasty is a minimally invasive bronchoscopic procedure for carefully selected patients with chronic severe bronchial asthma, where thermal energy is delivered in a controlled manner inside the airways to burn the submucosal tissue. What happens is that these patients undergo airway remodeling. As a part of airway remodeling, the submucosal muscular layer, the muscle layer in the airways, inside the airways, thickens over a period of time, adds rigidity to the airways and does not allow the flexibility for the airways to open and collapse. So they remain collapsed in all the situation. So we give them thermal energy inside, and I'll show you how we do it. Again, there are 8,000 plus patients data who have received this therapy and have done very well with the treatment. There's a short video to show that, where you introduce the bronchoscope into the airways, go deep inside the airways, up till the 8 to 10 mm airway you can reach and do a bronchial thermoplasty there into the peripheral airways. This is the catheter which is called the air catheter, which is then introduced inside. It has 4 prongs which are opened and brought into a close proximity to the muscle wall, and then this is connected to a machine outside which delivers the energy. With this energy that is delivered, the muscle layer thins down over a period of time. So this is done as 3 sittings over 3 weeks apart. So it's a 9-week therapy that is given to these patients. And after that you see that the dosage of ICS, the steroids, oral corticosteroids and other therapies comes down significantly, and the exacerbation rates also come down significantly. A very simple procedure, but very tedious and very time consuming, I would say. Then Allergen immunotherapy is another component, add-on therapy, which I leave for Dr. Amina to handle. We also give vaccination to all our patients. You all know vaccination has been my passion. We've done a couple of sessions on vaccinations also earlier. So influenza vaccine is strongly recommended. Pneumococcal vaccine is plus minus, doesn't show much benefit yet. But of course, if the patient qualifies because of other reasons, may be given the benefit of pneumococcal vaccine. Also because pneumococcal diseases are seen to be more common in patients with bronchial asthma. Then there are the non-pharmacological treatments like cessation of smoking, yoga, pranayama, physiotherapy, exercises, vaccinations, avoiding exposure, physical activity, healthy diet. All these things do contribute in overall improvement of the patient's health, and we also need to manage their comorbidities like obesity, GERD, anxiety, depression, food allergies, rhinosinusitis, nasal polyps. All these need to be addressed. Despite all this, there would be a subgroup of patients who have an uncontrolled or a severe asthma. You've done all this and yet the patient is continuing with the symptoms. So again, this brings us to three terminologies. Uncontrolled asthma, where there is either a poor symptom control or frequent exacerbations. When we say frequent exacerbations, that means more than 2 exacerbations in a year requiring oral corticosteroids, or more than 1 requiring hospitalizations. Then there's a difficult to treat asthma. It does not mean that the patient is difficult. It basically means that you've been giving everything, yet there is something lacking somewhere. So you need to look at the adherence, the inhaler technique and all that, whether the patient is really following it or not. If all this has been corrected and yet the patient is not improving, then you label the patient as severe asthma. And then the game plan for the patient changes completely. This happens in about 4% of the total patients who would be labeled as severe asthma, but that 4% also considering our Indian population and the number of patients suffering with asthma would be huge. You know, numerically it would be a huge number to have. So again, in these patients, you confirm the diagnosis, if possible relieve the allergen, look at the risk factors, assess the comorbidities, consider the treatment step-up therapy, yet not, then you need to refer the patient to a severe asthma clinic like ours, where we would do all these testing for these patients. We would also look at if there's any autoimmune disease underlying, skin prick test, allergen immunotherapies. These are all the options that would be given to a patient like this. Sorry, I've gone a bit too fast. These are the newer biologics that are available now. There's an anti-IgE omalizumab that is used for patients with severe allergic asthma, anti-IL-5 mepolizumab, reslizumab, anti-IL-5 receptor, benralizumab, anti-IL-4 receptor, dupilumab, which is not available in our country till now. Anti-TSLP is the newer drug which is available internationally but not in our country. But this is the first time it has been included in the 2022 guidelines. So our first step to such a patient would be to reconfirm the diagnosis, check the adherence therapy, rule out any other comorbidities or any other causes that could be causing breathlessness, and then confirm the patient and start the patient, evaluate the patient for benralizumab. Benralizumab is the anti-IL-5 receptor drug that I just mentioned. It is best suited for patients who have a late onset asthma, that means more than 18 years of age, higher absolute eosinophil count, more than 300, patient dependent on oral corticosteroids, patients with frequent exacerbation, more than 3 in a year, decreased lung function, and history of nasal polyposis. And then you would keep evaluating them every 4 to 6 months to the response. It works at the IL-5 receptor on the eosinophils, and which then get killed by the natural killer cells, resulting in apoptosis. So basically the eosinophilic inflammation is taken care of with this. The eosinophils literally become 0 in the blood, and so also in the airways there is a reduction of 96% depletion with the use of this drug. There are various studies that have been conducted. The Sirocco and Kalima trial, which are the pivotal trials looking at the reduction in exacerbation with the use of this drug. Then the Zonda and the Ponte trial, which look at the use of the drug and resulting in oral corticosteroid sparing effect. And then we have the BORA and the MELTEMES trials, which are long extended trials to look at the safety and efficacy of this drug in this patient, in this group of patients. So, in the CALIMA, Sirocco and Zonda trials, it was seen to reduce the acute exacerbation rates by 20%, 51%, increasing till 70% in 28 weeks. So significant improvement with the use of drugs. Oral corticosteroids could be spared to the tune of 75% as compared to 25% with the use of placebo in this group of patients. The long-term effects have also been quite safe. They haven't found much significance, much increase in the side effect profile. In fact, looking at it, there was a 63% reduction in acute exacerbation in the first year, 74% reduction in second year, and 87% up till 5 years, with no increase in the safety concerns related to the drug at all. In fact, even the lung volumes improved, the FEV1 improved from 239 to 343 to 364. To look at, it may sound that there's hardly an increase, but believe me, a 100 ml increase in the FEV1 is very, very significant. Benralizumab usually aims at getting a zero oral corticosteroid usage. So in the Zonda trial, there were about 52% of the patients originally with less than 12.5 milligram of oral corticosteroid could be reduced to zero literally. And 77% of the patients did not experience any exacerbation. The Ponty trial basically looks at the extended safety and efficacy. And in this, 62% reduced their OCS to zero and 74% had zero exacerbation versus 16% at baseline. But is there any side effect of zero eosinophils in the body? Again, there are various studies which have been conducted to show that there was no difference in complications or any difference in the outcomes in patients when the eosinophils were reduced. So the upper respiratory infection was similar in the two groups, 8%. In fact, it was higher in the mepolizumab group. Pneumonia rates were less than 1%. In the mepolizumab group, they were slightly higher. Helminthic infection was 0%. And malignancy rates were less than 1%, which was similar to placebo. So with the use of benralizumab since 2008, some 83,000 odd patients have benefited over the years. And there have been no new safety signals, no new safety concerns, no association with treatment and increased risk of exacerbations, and no relevant differences in the risk profile for anti-IL-5 receptor or anti-IL-5 drugs. This was as far as the experience conducted in the randomized controlled trials was concerned. Now looking at the real world experience, when you look at omalizumab, it only corrected the allergic phenotype about 40% at more than 2 exacerbations per year, and more than 25% had more than 4 exacerbations per year. When you compare it with mepolizumab, benralizumab definitely had a greater eosinophilic depletion effect. The exacerbation rates were also lower in the benralizumab group, in the real world, as well as irrespective of the IgE levels. As compared to mepolizumab, it resulted in reduced annualized exacerbations, reduction in the median prednisolone dosage, and improvement in the FEV1 rates significantly. And this was seen also in patients who had received a biologic prior to this. So the benefit in people who had received biologics and those who had not received biologics was almost similar, 83% and 89%. And the dosage elimination could occur in 54% of the patients who had not received a biologic and about 41% of those who had received any other biologic in the past. The advantage of using benralizumab also is that it gives you it requires lesser dosages as compared to mepoli or omalizumab. The maintenance dose is every 8 weeks as compared to other drugs, which is every 2 to 4 weeks or 4 weeks. So it gives you a 74% patient at zero exacerbation in year 2, sustained reduction in exacerbation through year 5 with no significant increase in safety concerns. Up to 62% of patients reduced OCS used to 0. And a safety profile that builds confidence with benralizumab being studied since 2008. And finally, Bronchial asthma is a common condition. LABA and ICS, as I said, is the preferred combination. Severe asthma is a distinct subgroup which requires proper workup and a scientific approach, and use of biologics has changed the landscape of management of patients with severe asthma. Benralizumab stands tall amongst all the biologics that we have available with us. Thank you so much for a very patient hearing.
Very well.
Thank you, sir. I think you have taken a little more time than we expected, because we have lot many questions. We have question masters here, more than 5-6 yaksh, I would say. Every yaksh having 100 questions. So let the next speaker quickly give the presentation so that we interact. Actually, interaction means more. It gives more take-home message.
Yeah, I'm sorry about that.
Yeah, please.
Very good. Thank you.
Namaskar, good evening everyone. It is indeed extremely overwhelming and a privilege for me to be standing here in front of such learned and experienced crowd and to be speaking something about my work. So Dr. Nangia has already explained in detail the various levels of asthma, severe asthma, and how we manage. Only when a patient does not respond to the first line therapies that we move on to the next line of therapies, which is the biologics and allergen immunotherapy. So just in brief about how all this allergic, non-allergic eosinophilic asthma works. So there is the allergen that then presents to the dendritic cell, which is the antigen presenting cell. It then activates the T cell. The T cell acts in two ways. It releases multiple interleukins against which these biologics function. There is either a production of Ig or the activation of the eosinophilic cascade, which we will see in detail subsequently. So coming back to our GINA steps in the management of asthma, basically what I'm trying to tell here is that your allergen immunotherapy and the sublingual immunotherapy is useful up to GINA step 4. Beyond that, once the patient has already reached GINA step 5, there is no role of allergen immunotherapy, and biologics is what is indicated worldwide. So beginning with a little bit about allergen immunotherapy and skin prick test. This is one of our own patients in whom we did a skin prick test for about 26 allergens, and of them the most positive response was for HDM, house dust mite, and we started this patient subsequently on allergen immunotherapy, and she has shown good results, though not immediately. So if we see the grading of the skin prick test, grade 0 is a negative control, 1 is 1 millimeter more than control, 2 is 2 to 4 millimeters, 3 is 5, and 4 is wheal with pseudopods. A little bit in brief about allergen immunotherapy. It is basically repeated administration of allergen extracts in increasing doses, basically in the same way that a vaccine works. It leads to control of symptoms during subsequent natural allergen exposure. It's highly effective in IgE-mediated disease in patients with a limited spectrum, 1 or 2 allergens. If you have multiple allergies, then allergen immunotherapy becomes difficult to, you find it difficult to form the vaccine, and secondly, there's not good response as well. So the indications are allergic rhinoconjunctivitis or asthma due to seasonal pollinosis. Patients with perennial disease also respond to this, particularly with patients who have allergies to house dust mite and animal danders, very, very commonly seen in our clinics. In patients who develop systemic anaphylactic reactions to wasp or bee stings also, this may be life-saving. So, as we all know, allergen immunotherapy can be subcutaneous or sublingual. Unfortunately, in India, till now, sublingual immunotherapy is not recommended. We do have sublingual immunotherapy for HDM and GRAS, but that is all in European countries. So there's lots of evidence in favor of AIT. There's a recent RCT of about 400 patients that showed that persons with pollen allergy would show 30% decrease in seasonal symptoms, 44% reduction in anti-allergic medication. Multiple Cochrane reviews have demonstrated significant improvements in symptoms, reduction in rescue medication, and improvements in allergen-specific bronchial hyperresponsiveness. So what happens once we stop the allergen immunotherapy? The patient who comes to you will say, will I continue getting these injections throughout my life? So in the largest double-blind placebo-controlled withdrawal study, 3 to 4 years grass pollen immunotherapy led to a sustained reduction in symptoms and rescue medication for at least 3 years following discontinuation. Other studies have also confirmed similar benefit. Moving on quickly to the biologics in severe Th2 asthma. Now Th2 asthma is a subtype of asthma that is predominantly allergic, involving IgE cascade either or the eosinophilic cascade. So again back to the same figure where we see interleukins being released, activating the B cells leading to release of IgE. There in the corner we see omalizumab, which is an anti-IgE therapy. Then we see Nucala or mepolizumab, which is anti-IL-5. And here at the bottom is the Fasenra or benralizumab, the mechanism of action of which has been discussed in detail already. So the approved biologics in India so far are omalizumab, which is indicated in moderate to severe persistent asthma for people more than 6 years of age. The dose is 75 to 375 mg based on 1, the IgE levels, and 2, the body weight. For IgE levels usually more than 700, we give the standard 375 mg dose. But there are no studies or trials that define a particular dose above IgE levels of 700. The frequency is 2 to 4 weekly. The risk factors would be anaphylaxis, dermatological and neuromuscular effects, which are seen with omalizumab. Mepolizumab is the second one. We'll discuss this in detail subsequently. It's also used as an add-on maintenance for severe asthma. Here the age group is in the adolescents and adults more than 12 years. The dose is rather simple, 100 mg subcutaneous 4 weekly. Very minimal side effects restricted to headache, injection site reaction, etc. Benralizumab is indicated in patients more than 18 years of age. The dose is 30 mg subcutaneous. So initially we give a 30 mg dose every 4 weeks for the first 3 doses, and then we increase the frequency, decrease the frequency rather, to every 8 weeks. So a little bit about omalizumab. It prevents IgE from binding to its receptor on mast cells and basophils. 2014 Cochrane review, which studies 25 RCTs, showed that omalizumab reduced exacerbations by 25% and reduced the ICS use. Recent trial demonstrated similar benefits in Th2 high and T2 low asthma. So now they're saying that even in patients who do not have the classical inflammatory phenotype of asthma, one may try omalizumab, but again, no randomized controlled trials for it. It's indicated in ages more than 6 years, so this is the only biologic which you can give in the pediatric population. The other 2 are mainly for adolescents and adults. And as I just discussed, the dosing is based on the IgE levels and the body weight. So over long-term therapy, this drug also reduces IgE production. So clinical efficacy with treatment cessation after long-term use is seen. If we see the real-world studies with omalizumab, typical patients receiving omalizumab are 1, younger in age, like we just saw, have early onset asthma. There's a higher reported history of comorbid atopic conditions. Omalizumab response rates are around 77% with associated significantly improved exacerbation rate, FEV1, oral corticosteroid use, and healthcare utilization. Long-term safety profile is also well established. Now, when the anti-IL-5 group is considered, we basically have mepolizumab and benralizumab available in India. Reslizumab is an IV injection, it's still not available here. So before discussing in detail about the anti-IL-5 therapy, just a quick word on what eosinophilic asthma is. So it is common, recognizable. The prevalence of eosinophilic and non-eosinophilic phenotypes in the population with severe asthma. Adult patients with severe asthma and available blood eosinophil count from 11 countries enrolled in the International Severe Asthma Registry between 2015 to 2019 showed that the eosinophilic phenotype can be identified by elevated blood eosinophils or clinical features such as comorbid nasal polyps, positive response to steroids, oral corticosteroid dependence, adult onset asthma, this is very important here, and frequent severe exacerbations. So it's also seen in multiple analysis and studies that patients with elevated eosinophils have frequent exacerbations, poor asthma control and lower lung function. So mepolizumab prevents IL-5 from binding to its receptor on eosinophils, approved for patients more than 12 years of age, 100 mg administered every 4 weeks. The largest trial for this was the Sirius trial, which showed an OCS reduction of about 50% reduction in exacerbation by 32% and an improvement in overall asthma control. Another major trial for mepolizumab was the DREAM trial, which showed no significant change in FEV1. So this is to be noted. A recent Cochrane review, however, showed that when they studied multiple studies on mepolizumab, they found that FEV1 was in fact increased by about 110 ml over placebo. The FDA has set no absolute eosinophil count for administering mepolizumab. However, the RCT suggests an AEC of more than 150 per microliter. It's also indicated for EGPA or vaginal granulomatosis, as we commonly call it. It's indicated for chronic rhinosinusitis with nasal polyps and also indicated for eosinophilic esophagitis. Now, one more important thing which I've not mentioned here on the slide is that prior to administering mepolizumab in patients more than 50 years of age, it is essential to vaccinate them with the zoster vaccine 4 weeks prior to onset of treatment, because that is a risk factor. Benralizumab has already been covered in detail by Dr. Nangia, so I will probably skip this. Okay, so coming to the concept of responder and super responder. So in the real world studies, we see that a responder is a person with more than 50% reduction in exacerbation frequency and or maintenance OCS dose, whereas a super responder is a person with 100% reduction in exacerbations and of OCS at 1 year. So there were these two major publications, both in the CHEST journal, where they studied mepolizumab as well as benralizumab in severe eosinophilic asthma. So in the real world, we saw that in mepolizumab, the super responders were 28.3%, whereas in benralizumab, the super responders were 46.9%, which means that at the end of 1 year, the cessation of oral corticosteroid therapy in patients receiving benralizumab was to the tune of around almost 50% of those who received the drug, which is quite a relevant figure considering that most of our patients who come to severe asthma clinic are often on oral corticosteroids, living with it rather. So OCS sparing, is it real or just a hoopla? So we have a comparative chart here between benralizumab and mepolizumab with the major trials. Median OCS dose reduction in the Zonda trial for benralizumab was 75%, for mepolizumab in the Sirius trial was 50%. When you compare the proportion of patients with 100% reduction in OCS dose, again higher in benralizumab. Proportion of patients with 5 milligrams daily, again higher in benralizumab. And the exacerbation rate was reduced more with benralizumab as opposed to mepolizumab. Also, this is one more interesting paper in which they first studied the CT scans of the patients with severe asthma, and they calculated the mucus score. And it was found that people with high mucus score, So we could, extrapolate it to the fact that people with more phlegm-producing kind of a phenotype responded better to benralizumab. So again, if we see the characteristics, the patients receiving anti-IL-5 therapy as opposed to those receiving anti-IgE therapy are older in age, have adult onset asthma. For IgE, we have young onset asthma. These patients are predominantly males, have a high prevalence of nasal polyposis. Nonetheless, not all patients respond. Those with a more severe baseline disease, measured in terms such as asthma control questionnaire 6, were less likely to respond and super respond to these drugs. So what do we do then? We'll come to that. One more important thing which I wanted to discuss here today is that a lot of patients also come to our clinics with persistent cough. It's not essentially asthma but an isolated chronic rhinosinusitis with nasal polyposis. And many of these patients have already undergone FES surgeries, and they come back to us in a year's time, sometimes 2 years' time, again with nasal polyps, postnasal drip and persistent cough. Now, this is slightly unrelated to asthma, but even in this case, there have been studies and meta-analysis that have shown that dupilumab was the most preferred biologic for chronic rhinosinusitis with nasal polyps, followed by mepolizumab, followed by omalizumab. For isolated nasal polyposis, there have been no meta-analysis or RCTs as far as benralizumab is concerned.
Can you please summarize?
I have a couple of cases to discuss, sir, if that is okay, or we can maybe...
We can discuss actually. Yeah. We have so many cases in our mind. So we can...
Okay, so one more important thing which I'd like to mention here is that...
Take home message, and we have so many questions to elaborate our queries.
So one important thing is that we don't stop before giving the patient 4 doses of any biologic because the effect is seen only after that. I'll skip the cases. To summarize, the treatment of asthma has evolved by leaps and bounds. The management is no longer restricted to bronchodilators and steroids, and there is an emerging need of specialized asthma clinics and personalized care for each asthmatic. Thank you very much.
You will please come here. Dear friends, what a rich talk we had. 2 speakers, 1 legend and 1 going to be legend. Yeah. So, as per new PFI, as per new PFI guidelines, we have the protocol to let the non-Tulsi group ask questions first. Stage 1. Then stage 2 by Dr. Tulsi et al. Before I set the ball rolling, sir, let me just express myself. I was amused to see there is a lot of difference between diabetes and asthma, and there is a lot of similarity. Similarity is that asthma and diabetes both are progressive chronic diseases. They have control, no eradication. There we have glucometer, here we have peak flow meter. There we have a response, pre and post dilator. There we have fasting and PP response. Sir, I will not go into details, just wanted to ask thermoplasty, how much it costs in your center?
So bronchial thermoplasty, against all the hype around it that it's a very expensive procedure, costs not more than 5 lakh rupees. Considering all the trauma and even one single hospitalization in the hospital, like ours, we got probably as much only. So if you're able to save that hospitalization, I think it's worth it.
School for thought. Botox will be used sometimes in that, or some newer laser, the green, the yellow, I don't know, so many colors of lasers are coming. Will they be helpful in this thermoplasty or whatever thermoplasty?
So of course we can always expect more lasers to come in and more newer ways of correcting the underlying muscular hypertrophy. Basically it's a muscle hypertrophy. So Botox would actually result in greater hypertrophy and greater stiffness. Botox, what does Botox do is basically elevate it acts as a filler. So we don't need fillers there. It's already overfilled. We need to reduce the filling inside.
So I will take no more time, just starting with Dr. Sen Gupta, who is standing apart. Sir, and then Dr.
Quick few questions. Thank you so much for a phenomenal 2 lectures. So in the adolescent group, which should you choose between omalizumab and benralizumab and why?
That's a very relevant question, sir. So basically, omalizumab primarily is for patients with an IgE-mediated disease. So the first case which I was going to present was a person with severe persistent asthma and an elevated IgE with normal eosinophils. So if it is just an isolated IgE with normal eosinophils, you're going for omalizumab. If it is an elevated IgE along with eosinophilia, then we choose benralizumab.
And the difference in cost, if any?
So sir, omalizumab per therapy, per injection is roughly about 30,000. The frequency is 2 to 4 weeks based on what your IgE level is. As far as benralizumab is concerned, it's a fixed dose, sir, 30 mg subcutaneous. The cost for entire 6-month therapy comes out to be around 2.25 lakhs, which if you break it down into 6 doses is almost the same as omalizumab. So the price...
So what would be, for all of us, quick clinical considerations to consider a monoclonal antibody for any patient who is obviously in a severe asthma, but when you have to counsel the patient regarding, that he or she needs a monoclonal antibody, what would be a quick consideration to see the clinical portfolio?
So a couple of things which I always tell the patients in my asthma clinic is that, sir, one, you're going to get rid of your oral corticosteroids. If not now, then subsequently. It doesn't happen overnight, but over a period of time, like about 3 months. The second important thing is that the cost of one exacerbation is much more than the cost of entire therapy here, at least in the private sector. So these are the 2 things which I explain to them. For my own sir, if the patient has severe uncontrolled asthma and with an elevated IgE, it's omalizumab. If there's an element of eosinophilia, I'd rather prefer benralizumab.
And the allergy test, ma'am, what are you doing? Patch test, injection test?
I'm doing the injection test.
And do you do the Fadia top and then do a corresponding thing?
So, yes, it's a combination of both, sir. Basically, first a detailed history pointing towards what specific allergen it could be. Then we have 3 panels, food, then drug dander, dog and cat dander, cockroach, HDA, and then there's the 4th panel of molds and fungi.
So how long does the test profile take to be reported?
It's instant, sir.
Instant, absolutely. So you do not do a patch test, ma'am?
No, we don't do it, sir.
And lastly, thank you so much. The thermoplasty that Dr. Kalra sir was also referring to, is it a semi-permanent or a permanent kind of a thing you're looking at?
No, sir. So again, we are looking at reduction in exacerbations here.
Yes.
The patient continues.
But for how long approximately the time frame that we are looking at?
So we have studies till up to 5 years.
Thank you so much. Thank you for the info.
Dr. Amish Vora, our professor of oncology, who has his own setup in Postcards, and we have been supporting him, and he's been kind enough to come today. Actually, we have 4 DMs today. We have a DM oncology, we have a DM neurology, and we have DM gastroenterology. So it's tribute to the forum.
Thank you. The question to both Dr. Amina and Dr. Nangia. We live in the world of precision medicine. Eosinophilic bronchial asthma, and pardon me for my naivety because I don't see pulmonology cases. Eosinophilic versus non-eosinophilic becomes a very broad category. And the phenotype slide which ma'am you showed also again to me becomes a very broad category. Are we delving into a genotypic bronchial asthma? And so like benralizumab or omalizumab will work for this particular genotype and will not work for this particular genotype, rather than just looking at only the phenotypic and eosinophil count to me looks little, naive sort of thing. But again, my apologies if I have asked the wrong question.
No, you're absolutely correct, sir. In fact, if we compare the monoclonal antibodies that we give in oncology patients, they're all based on genotype. So I see where the question is coming from, but unfortunately, so far, we don't have any genotyping. Hopefully, in the years to come, we may be able to identify patients based on their genotype.
Sir, we have a question. We have our DM gastroenterology, Dr. Shubham Vats, and he deals with lot of reflux cases, and I keep referring cases to him thinking they are asthma. They come back to me and he tells me elevate their head end and put them on prokinetic and PPI. He has a question to us.
Sir, a very good evening to all of you. And Nangia sir, I've heard your name a lot in the past years because I've just grown with that phase. My grandfather was your patient when in Fortis, I guess, when you were back there. So, and my grandfather is healthy. He's 95, he's COPD, but keeps well with after 15 ICU admissions. But coming to my topic, I was just thinking that how do you feel that with the atypical GERD presenting with breathlessness, burning in your throat and all of these symptoms, and you give them ICS, like you said that inhalational corticosteroids are a cornerstone of therapy. How would you deal with these patients if they have a reflux, exacerbating asthma, and the inhalational corticosteroids exacerbating reflux? So would you put all of these on what do you call PPIs, or would you how would you think about it, or is it only my perception that because I'm tubular, like you're tubular into lungs, I'm tubular into the GI tract, so that kind of thing will come out?
Again, a very valid question that you've asked. So I think when I say 80% of our patients sinusitis, 70% of the patients also have a GERD. And we have to treat both of them together, otherwise, one single organ targeting would actually result in a tubular vision that you're saying will not be effective at all. So invariably, most of these patients do land up on a PPI as well.
And so what's your experience with inhalational corticosteroids leading to what you call esophageal candidiasis?
Esophageal candidiasis is not so common, but oral candidiasis definitely is very common with the use of inhaled corticosteroids. And but again, you have to teach them the right way of doing it. In fact, earlier we would recommend doing an oral rinse, but with now time is realized that oral rinse also is not as effective. But definitely, if they take it properly through a spacer, then the chances of oral candidiasis are also low.
Okay. So, sir, in my experience, I've seen a lot of esophageal candidiasis without immunosuppression. So, we were just thinking that with all these things, do they play a role? I think it needs more attention. Thank you so much, sir.
Thank you, Dr. Shubham. We have Dr. Bansal, owner of Bansal Hospital in New Friends Colony. He has a question.
Sir, my question is in our general practice, we see a lot of patients with post-nasal drip, only coughing, no wheeze, nothing. How to tackle those patients, and they come repeatedly only for this. We have to give antibiotics and all the drugs. How to tackle them on a long-term basis?
So this has got a new terminology completely now with the syndrome that you're describing. This is called an upper airway cough syndrome, which is usually associated with the post-nasal drip. How we treat our patients is with the help of local nasal steroids and decongestants. Azilastine is a good drug to use, along with an anti-allergic and again a decongestant. Again, first line anti-allergics are supposed to be better in managing it, like chloramine and all. The first line antihistaminics are supposed to have a better effect in controlling this kind of a cough. Then of course you could use symptomatic cough suppressants, lozenges, and then the benzoate. That's a very good drug to use to control the cough. Also, very often your post-nasal drip gets mixed with GERD. So it's a good idea to add an anti-reflux drug also. That's like a cocktail you would use in your patients to control the cough. And if still it doesn't come under control, then you have things like methylprednisolone, gabapentin, all that can be used. Oral inhaled corticosteroids can be used. Inhaled corticosteroids also help relieving the inflammation inside the upper airways. So they can also be used.
Dr. Nangia sir, you would remember the first interaction we had with you was in 2009 at a place called Parkland. it was in Green Park, and your chairperson was Dr. P.K. Mangla.
That's right, absolutely.
Sir, he has a score to settle with you. He has a quick question.
P.K. Mangla is a very dear and senior colleague, very respected
No
senior
scores
colleague.
to settle. Actually, I think the topic has been very well covered. But what I want to say, the figure of absolute eosinophil count of 150 and 300. If you take a TLC of 8,000 and 4% of eosinophils, I think majority of the asthmatics would fit into this. That is one part. That means to all these patients, they will be fit if they are asthmatics. And most of them, asthmatics will have this kind of eosinophilia unless they are non-eosinophilic variety. So what I want to say is that cost is a big factor in these. And you cannot tell your patient that you will get rid of your steroids. Your steroids 10 milligram का 5 milligram हो जाएगा, 20 का 10 हो जाएगा. That is one thing that you cannot guarantee that your steroid will be off steroids in these patients. Then most of the patients who come to hospital OPDs, I think they are already on inhalers. Whether they come to you with variant asthma or whether they come to you with acute exacerbation, short of oral steroid, they don't settle. That is one thing for certain. Then there is a brand of patients in whom you give steroids. Not many of them will relapse. डॉक्टर साहब बहुत अच्छा लगा, पहले 5 दिन तो अच्छा लगा, जब ये बंद किया तो फिर से symptoms शुरू हो गए. So these are certain things I would like to mention. And how does this benralizumab behave in patients of ABP? Does their steroid consumption comes down? Because the basic treatment besides itraconazole is steroid therapy in these patients. Do you have any experience of treating ABP patients? Because they are primarily asthmatics.
Sir, we have more studies with omalizumab in ABPA. In fact, one of our patients has been on omalizumabs for the last 5 months now. Yeah, he just came for his 5th dose and he is actually off steroids, sir, so far. Fingers crossed.
No, in between they are not. In between the ABPA patients will be off steroids anyway also. Once they relapse, then you check that they have developed a collapse. That is what asthma is. We had done a study when I was an MD student, Professor Menon. We had done a very large study on this immunotherapy. And it was a double-blind study. And in this study came that the placebo did better than the immunotherapy. So we stopped doing it. I don't know what is the present status.
This is the allergen immunotherapy.
Of course. It was in Patel test and it was done on, I think, 7,000-8,000 patients. And the key was with Kerala. So nobody knew who was getting what. Second thing is EGPA is Churchross or is it Wagner? I think it's Churchross.
It is.
GPA is Churchross.
You mentioned Wagner.
GPA is Wagner.
Sorry, my bad, sir. It is Churchross, yes.
I knew you would have to say sorry to Dr. Mangla.
I didn't even realize when I mentioned that.
No problem, ma'am. Dr. Sen certainly has woken up.
Come back to Dr. P.K. Mangla's comment. I would like to say something.
Sir, please.
That it is not every asthma with eosinophilia that we are treating. It's only patient who has severe asthma, uncontrolled with regular medication. There you want to classify the patient and see which drug will benefit the patient. There you would want to use benralizumab. And not that any patient who's walking in with eosinophil of 400, 500, 600, it is not so.
What I'm trying to say, it is not that. What I'm saying, the figure which they have mentioned for the use of this drug, majority of the patients will have this kind of eosinophilia. That is well understood that if patients are relapsing.
Again, sir, basically, so this is what the guidelines say. And also that even if the IgE levels are normal, even then the patients benefit. Even if the eosinophil levels are slightly elevated, in fact, they've taken 150 as the cutoff if they have very frequent exacerbations. So, of course, they're all backed by certain studies.
I was wondering about this figure of 150 and 300.
All the studies that have been conducted according to this, and they're all randomized controlled trials and meta-analysis that have been published. 83,000 patients, not a small number. You're talking about 8,000 patients of allergen immunotherapy, which was like years back, decades back now. And from there to now, the science has evolved so much. The targeted therapy, look at the chemotherapy at that time and the chemotherapy that is being done now.
No, agreed.
People were dying of chemos then and now they're tolerating it so well. Lung cancer disappearing completely. with oral chemotherapies.
No,
have you ever heard of, did you ever think of that ever?
We all know that these,
we've come a long way from this.
Prodizumab and all, they are working, doing wonders.
They're really going wonders.
They are doing wonders. But I'm trying to say that asthma is not perennial in majority. If somebody is suffering from asthma for 1 month, anyway he is alright for the whole year. Or if he is
so that patient doesn't need any treatment there.
So because all these...
So then the patient falls into step 1 or step 2 where only an ICS lava needs to continue.
Actually, problem lies that most of the patients in remission are controlled with ICS lava. When they are visiting the hospital, short of oral steroids, they don't do well.
That's alright.
And then
Short of oral steroids, there is no harm at all.
That is what I am trying to say. Actually, they are trying to cut down on steroids.
We are talking about prolonged course of steroids.
Dr. Vivek, sir, just a minute. On behalf of everyone, there are some questions that I like to ask, as at every time. Sir, many of our patients, they are asthmatics, they also have cardiac issues. We don't have, white and black, we have shades of grey. And many of these patients, on account of coronary artery disease or acute coronary syndrome, PTCA, they have to be put on beta blockers.
Aspirin.
My question, sir, very specific question is, if a patient of bronchial asthma, he gets ACS and then gets a PTCA, gets treated well, and then is put on a beta blocker, he comes back with recurrent exacerbations of asthma. Sir, what is your strategy for these people?
Very good, sir. Very valid question again. There are always an overlap. CAD is always an overlap with COPD patients, bronchial asthma patients. So, but we don't hold back the beta blockers in these patients. We give them a super selective beta blockers, like carvedilol. Atenolol is not to be used. Metoprolol may be used. Carvedilol is safe.
Can we use nebivolol, which is the super selective?
Can be safe to use. That's absolutely.
It can be used.
That's the safest.
Now, sir, even if we use a small dose of beta blocker in certain subset of patients, they keep coming back with remissions. What is your strategy in these people? Do you tell them not to use a beta blocker at all? I asked Dr. Mangla sir one day, and he said, if you have a case of severe COPD and bronchial asthma with remissions, with exacerbations, try and not to use beta blockers. His advice was, try and use the minimum dose of beta blocker, maybe even 12.5 milligram of metoprolol. So your advice on that?
So instead of metoprolol still has some tendency to cause bronchospasm, but nebivolol and carvedilol have no tendency at all. They work on a different set of beta receptors completely. So there is no interaction there. So they are safe to use and recommended to be used in this situation.
Sir, what about aspirin here? This is also important.
Please.
Aspirin.
So again, if a patient does have a particular aspirin-induced asthma, then you possibly can't be using aspirin in those situations. But you could use one of the biologics if you have to use, and despite aspirin, there can be aspirin desensitization also that you can consider, and of course, clopidogrel is there as a substitute.
Sir, my other question is, I heard Dr. Amina on biologicals, ma'am, and they happen to be very costly, sir. For a routine asthmatic, we have a lot of poor people. And I was speaking to the AstraZeneca people once, and they said that they have a scheme. If you buy a certain portion of the injections, then they give another portion of the injections free. Is it possible?
It is there.
Is there a scheme?
It is there.
That we can give for, let's say, 3 months, and 3 months is free?
We can always talk to them, sir.
No, for the larger audience, sir, because they all treat asthma.
Yes, I'll divert the question to them only if they have.
Do you have an answer to that?
Yes, sir.
Yeah. Good Sevak.
Yeah, good Sevak will give the
The
answer.
person from Guru, and he is a Sevak for everyone. Good Sevak, my good friend. Can you answer this question?
Yes. So in India, we are providing some patient support program for the patients who are falling under the severe asthma category. So as we know, these brands are very expensive in Western countries. So here is also the cost is almost 2.25 lakh MRP. So but we are providing some of the free vials we are providing to the patients so that the overall cost can be reduced and Indian patient can get benefited. So 6-month cost is 1.80 lakh. that is 30,000 per month. That is similar to the omalizumab also, as well as the mepolizumab. This is how we are helping the patients.
Thank you, Guru Sevak, for that feedback. Sir, kindly excuse me for this, and I am still on to beta blockers. Suppose my patient is not even able to tolerate 12.5 milligram. Can I go on to use a calcium channel blocker instead to control the heart rate? Diltiazem probably, or maybe ivermectin. Your comment, sir?
Absolutely, sir. Both the drugs are safe for treatment in asthma patients. Calcium channel.
Sir, it was a wonderful talk from the Legion and the Legion in making. I think Dr. Sen Gupta had a question, if he has not disappeared already.
Sir, कितने सवाल पूछवाओगे?
Sir, right. No, sir, there. We are coming to the master. Sir, your MD Viva is over. Your DM Viva starts now.
It is a DDM Viva, not DM. DDM.
Thank you, Dr. Chauhan and Dr. Kalra and Dr. Nangia and ma'am you as well for such wonderful insights. So Dr. Nangia, so most of the guidelines, international guidelines and national guidelines as well, talked about the regular use of SABA alone, which causes increased mortality. See, it explains, Gina explained why. Because it downregulates the beta receptors, rebound hyperresponsiveness occurs, decreased bronchoprotection occurs, increased airway inflammation occurs, increased exercise-induced bronchoconstriction occurs. So, we should never be using, you see, SABA now alone, always to be used with ICS. Sir?
That is what I would strongly recommend. That ICS forms the backbone of treatment of these patients. On top of that, you preferably should be using a long-acting bronchodilators. But if there is a situation where you want to use a SABA, then again it has to be with an ICS and not without an ICS ever.
Right. So traditional teaching, see, regarding anti-inflammatory effects of ICS, says that it takes days to occur, but recent evidence suggests that non-genomic effects start early, within seconds to minutes, and the genomic effects probably takes 4 to 24 hours to occur. How true is that, sir?
That's absolutely true, sir. In fact, there are studies which have shown that use of SABA over 2 weeks actually results in SABA becoming ineffective on the patient. So if you continue using a salbutamol or Duolin for longer than 2 weeks, it is not doing any benefit to the patient at all.
Sir, talking about xanthine, methyl xanthine derivatives, see, increased toxicity, increased cardiovascular toxicity, you have to regularly monitor the levels, but they have some role to play. Probably, they have corticosteroid sparing effects as well. So, are you prescribing methyl xanthine or you done away with it?
Methyl xanthines are used in a very selective group of patients where there is no improvement. Especially benefited in COPD patients as compared to asthma.
Right. Okay.
That again brings us to the thing that we must diagnose what you're dealing with. Is it asthma? Is it COPD?
Absolutely. So let's talk a little about the status asthmaticus or severe asthma. See, we get so many patients in emergency. I'm sure you may be getting so. So how do you treat them? So initially treatment with SABA. By nebulization every 20 minutes for 60 minutes, followed by hourly nebulization for several hours, including would be IV methylprednisolone as well, 125 milligrams every 6 hours, followed by oral corticosteroid. What do you say, sir?
Absolutely, sir. So 60 milligram of prednisolone is what is recommended to be given to such patients, along with frequent SABA inhalation and nebulization.
Right.
And then you could be adding a SAMA, you could be adding a LABA, LAMA gradually. But yes, first line treatment would be that only, along with oxygen support.
So, Dr. Meena, you talked about biologicals. See, December 2021, FDA approved severe asthma, not only eosinophilic asthma, all types of severe asthma. And this is an anti-LP therapy. So, 50% reduction, see, in acute exacerbations of asthma is a game changer. but very expensive. Is it available in India?
No sir, it's not. In fact, it's come just recently in GINA guidelines 2022.
Right.
It is one very expensive and two still not available in India. Maybe the Astra guys can help us with it subsequently.
What is unique about this drug, which is a game changer now, is that it is effective in all types of asthma.
Yes sir.
You know,
So in the chart,
unlike the other monoclonal antibodies which are effective only in eosinophilic. My final question, both of you. The COVID-19 and asthma. See, no increased risks, neither of infection nor mortality. Well, in well-controlled asthma, no excessive exacerbations seen during COVID-19. So in fact, it reduced. So ICS protection, does ICS cause any protection? Remember the stroke trial and the principal trial as well. We talked about giving ICS in COVID-19 patients early within the first 7 days. But there have been some recent changes, and the contained study, which was published recently in the BMJ, they said it's as good as a placebo. Sir, what about you? Your comments?
So I think sir, my take on this is that ICS usually helps controlling the asthma better. So that basically means
So
that
we're talking about in COVID.
Coming to that. And because of that, the inflammation in the airways is under control. If the inflammation is under control, then the risk of developing COVID is just as good or as bad as anybody who's healthy lung. So it is equivalent to that.
That's what we thought, sir, till the contained study, which was published recently, said, see, it's as good as a placebo. I don't know, there's some controversy there.
What I'm trying to say is that if the asthma is under control, so what does asthma do? Asthma basically results in an inflammatory cascade in the airways, which is an ongoing process. On top of that, if you develop a COVID, if the uncontrolled asthma, the inflammation is ongoing already, then your propensity to catch any infection, be it viral, influenza, COVID, would be certainly higher. And the rate of complication will also be high. If somebody is already on ICS and the asthma is under control, inflammation is under control, then their probability of developing a COVID-related infection would be as good or as bad as somebody with healthy lungs. Because the inflammation is under control.
Absolutely. Thank you, sir.
ICS does not have a role in COVID per se, but has a role in controlling asthma.
Right. Thank you, sir.
Dr. Sen has controlling the risk factor.
Dr. Sen has a question.
Sir, the severe asthma clinic, are there any packages or you're doing it on just on a consultant and test basis? Are there any packages?
They are all customized depending on the patient's needs and requirements.
So are there any routine packages that you're doing for the patient? No.
Per patient.
Per patient. Thank you.
Sir, dear friends, you must appreciate it was wonderful talk. Of course, we would have appreciated more if it was 2 talks, one per speaker, because we had to cut you, request you to summarize early. It was kind of interrupting you. I didn't relish it, but it was, say, need of the time. Sir, my few small questions just to carry home message. One is Saba and Lava, never alone. One is this one. Second, sir, adrenaline was used in my time when I was student very frequently, subcutaneously and otherwise.
Especially.
Yeah. So are you using subcutaneously still or aerosol? Are you using in any case?
So we are not using it, but if somebody is in a refractory stage where the patient is almost on the verge of getting ventilated, then you may use the inhaled form, but certainly not the subcutaneous form.
Sir, azithromycin, say thrice a week or so, for 3 months, is it not an antibiotic abuse? Because azithromycin otherwise given for 5 days works for a longer time. It has a longer duration of action. And what we are giving it for? Is it for anti-inflammatory effect or some? What is the cause?
It is for anti-inflammatory effect.
So we have
azithromycin is being used in asthma as well as COPD patients, especially those who are smokers. In them, the response has been shown to be very good. But of course, you have to keep in mind of antimicrobial resistance, QT prolongation, and GI disturbance. You have to keep that in mind and rule out that there is no atypical tubercular infection in the patient before starting.
So dear friends, I came across there was a cigarette used initially many years back, maybe centuries back, Grimaud's cigarette. It was containing atropine and cannabis for use in asthma. There were no inhalers at that time. So I don't suggest you for using that, but I would say presume if we have some e-cigarettes which we have banned containing something which is helpful for asthma. Yeah, something which can help.
It's a very innovative idea.
Yeah, it's an innovative idea. You are using something, say inhaler, nebulizer. This is a pleasurable thing. You gush maro or dum or kuch ho gaya. So my talk ends here, and I welcome all my friends for the next one.
I think all of you would agree that we had a legend on chest today, Dr. Vivek Nangia sir, and very able deputy Dr. Amina, speaking on biologicals. This is a very difficult topic and nobody can be perfect. No questions can be answered perfectly. That is why this subject remains a very, very challenging subject. My humble request to you is, when faced with asthma and when you are faced especially with uncontrolled asthma, and I would say very especially with severely uncontrolled asthma, consider sending your cases to Dr. Vivek Nangia sir and Dr. Amina. That is my carry home message. And I learned from their wonderful talk today that it's not about Saba or Laba alone. It's about their combination with ICAs. You are committing a big mistake if you are not targeting the issue of inflammation in the airways. If you are only trying to, flogging a tired horse, as they say, and only dilating the bronchioles. So it was a wonderful talk, Dr. Nangia sir and Dr. Amina ma'am. We thank you very much on behalf of the forum. And I think in such a challenging topic, I would request you, sir, not to associate with the forum after 11 years, after 2009. It's 13 years when we had a face-to-face meeting. Of course, it was interrupted by a wonderful webinar, but we need to meet more frequently. You would agree with that, sir? You would agree with that. Thank you. I'm very greedy about taking CMEs, and especially when it comes to meds, it is my greatest resource in the last, I would say, 18 years of conducting this forum on behalf of this brilliant crowd, consisting of people like Dr. M L Kalra sir, Dr. J.P. sir, our patron Dr. Mathur sir, and our president Dr. B.K. Gupta sir, and all the wonderful attendees here who come, spend their time here, give their time out of practice. And sir, 809, not a small figure, not a small figure. And what is more important is that it is a figure which is not interrupted. It is a continuous figure for last 17 years, every single Wednesday.
Thank you, sir. Very nice talk, man. I'd like to compliment Dr. Sushil Jawar and all the audience. What we happened to 809 is not a small thing. And it is a continuous effort by Sushil in such a way that he kept everybody in the group united, and we are the experts in the various fields. Like you, others experts have come. And we are really enlightened by your talk and educated by your talk. Thank you so much for everything. Continue, Sushil. Wish you all the best.
Looking forward to another CME, sir, probably in March, when the season changes, and you always say, don't stop your inhaler till May, till I see you. Or you come for follow-up. Changing season, get your flu shot, get your pneumonia shot if due, and continue with the inhalers I have given you. Monoclonal antibodies, yes, Dr. Amina, always there for our help. Thank you very much, sir, for this lovely talk. We feel privileged, honored, especially. Always say to everyone, फिर मिलोगे कभी, इस बात का वादा कर लो, एक और हसीन मुलाकात का वादा कर लो. मैं सर आपसे कह सकता हूँ, मैडम से नहीं कह सकता हूँ, क्योंकि प्रॉब्लम हो सकती है.
तारीख ले लो ना, तारीख पे तारीख ले लो।
तारीख सर मार्च में डन सर। थैंक यू। आई एम श्योर राहुल will see to it.
They are marching toward March.
Thank you so much, sir. I request everyone to be so patient and join